All right, thank you for joining us for today's event on medical review findings and outpatient rehabilitative therapy services. My name is Mary Sue Gardner, and I'm actually a registered nurse on the Provider Outreach and Education team. And I'm going to be your facilitator for today's event. And I'm joined today by Jennifer, as well as members of Medical Review, who are going to be helping out with the chat section, as well as the Q&A section for today's event. My overall objective for today is that you learn about the key coverage and documentation requirements for outpatient rehabilitative therapy services. We're going to achieve this today by discussing those outpatient therapy coverage criteria. We're going to discuss documentation for outpatient therapy and some common medical review findings. All right, so we are educating on this topic today because our medical review team actually has several different targeted probe and educates going on right now that all have to do with outpatient therapy services. So let's jump into an overview of kind of what's going on. So what's driving these targeted probe and educate? It's data. Data is the key to why we do what we do. So data analysis was done and has identified several different CPT codes that stand out in both our J5 and J8 contracts of work. Also both Part A and Part B services. So the CPT codes that stood out the most and are under targeted probe and educate are those that are listed here on the slide. So the 97110, which is therapeutic procedure, 97112, which is neuromuscular reeducation, 97150, which is therapeutic procedure group, and 97530, which is therapeutic activities. And we're going to break these down in the upcoming slides, but these are 4 different types of targeted probe and educate that are currently going on in our medical review department. So we'll start with therapeutic procedures, the 97110. These are therapeutic exercises to develop things like strength and endurance, range of motion, and flexibility. So these procedures generally require direct therapist contact or therapy assistant that's working under the therapist's orders. And it includes activities of things like resistance band training, stretching, treadmill work, strengthening with weights, postural exercises, and even balance training. They are generally aimed at restoring a specific function. So goals should address those isolated deficits in strength or range of motion or endurance or flexibility. Again, the use of this CPT code requires one-to-one contact, and the billing for that is in 15-minute increments with at least 8 minutes needed for 1 unit. So it's a timed code, so we always have to have time as part of our documentation, time in actual minutes. Next under review is the neuromuscular reeducation, or the 97112. So this is a therapeutic procedure involving reeducation of movement and balance and coordination and kinesthetic sense, posture, and even proprioception for like sitting or standing activities. It's generally used to correct dysfunctional movement patterns after things like an injury or a neurological condition. So activities under this may include things like balance training on like unstable surfaces, or activities like reaching, like getting things out of a closet, or, core stability like balance ball. Even biofeedback like EMG for that enhanced muscle control. Sometimes we see gait training with obstacles, so that helps with the balance. And other exercises to improve like body awareness and joint position senses as well. So these are just a few of the activities that we would look for to show that you're working on things to improve the brain's ability to communicate with the muscle and restore that normal controlled movement. All right, next is the therapeutic procedure 9715. So similar to therapeutic procedures individual are the therapeutic procedures group. So these involve procedures rendered to at least 2 or more people at the same time. This could include, but not limited to, things like aquatic therapy, resistance band exercise, those balance trainings we talked about, functional movement drills like squatting or walking or stairs. So all aimed at restoring function with the therapist being constantly present, but not necessarily one-to-one with each patient. So the therapist or the therapy assistant working under the direction of the therapist. The patients all may be doing similar or different exercises under that supervision. So the activities must relate to each person's unique goals, even if they're performed together as a group. So it's still got to make sense for your patient's goals, is what I'm saying. And then the therapeutic activities 97530, that's the final CPT that we are looking for under TPE review right now. And this, again, involves direct one-to-one contact with the therapist. So services under this CPT are considered skilled when they're dynamic, functional, and require the therapist's expertise to really improve that patient's functional capacity, such as reaching, bending, climbing stairs. So these activities generally focus on daily tasks of the patient. So think about things like lifting or carrying or squatting or transferring and even pulling or throwing. They're also generally not isolated exercises, but instead focus on whole body movements, like picking up a box and placing it on the counter, which is different than the therapeutic exercise like the 97110, which focuses on improving a single parameter like strength or range of motion. So let's move on and talk about the data-driven information that led us to these reviews. So why did we choose the 97110? The 97110 is actually a review that's happening in our J5 jurisdiction, Part A. So this problem was originally identified due to projects by the CERT contractor. So the CERT error rates were showing a high error rate for this specific CPT code of 28.3%. So then what we did is we performed more data analysis, and we actually identified 119 providers that were billing above a targeted threshold of 2,959.70 units per facility. So what does that mean? We just identified that 119 individual providers are billing more than the average of all other providers in their area. How do we know it's an issue? We don't always know it's an issue until we review the claims and make sure that the documentation supports what's on the billing and it's being provided in accordance with Medicare regulations. So moving on, 97112. This is a J8 jurisdiction, Part B. So this problem was identified due to CERT review findings as well, where they found that this specific CPT code was being utilized 13.2% more by certain providers. So the data analysis was performed, and this one identified 553 providers that were billing above the target threshold of 336.25 units per provider. The identified cause of this problem includes missing certifications and recertifications for outpatient therapy. And I forgot to say the identified cause of the 97110, I think I skipped over that. But the identified cause mostly in this problem was insufficient documentation. And again, that's per the CERT dashboard. All right. So why the 97150? So the 97150 is J5A, outpatient group therapy. The CPT code 97150 is group therapy. Again, it was identified on data as having a high utilization with a low dollar per claim rate, so less than $40 per claim, but high utilization. The units per beneficiary for J5 exceeded the national average of 6.28 and 6.02 units per beneficiary, respectively. So there was no CERT data error on this problem. So our data analysis, again, was performed and identified a couple of providers that were above the targeted threshold of 10.36 units per beneficiary, and more than 40 claims submitted in the last 6 months. So just because dollars aren't high doesn't mean it's not an issue if we find overutilization. But there again, we need to review the claims and see if there is an issue or if it's being reported appropriately. So the identified cause of this problem were things like documentation doesn't support the need for ongoing skills of a qualified therapist, and documentation was missing the number of individual participants, or the number of the individual participants that were present in the group therapy session. So remember I said for 97150, when you're billing that group, it has to be more than 2. So if it's not supporting that, or I think it's 2 or more, I'm sorry, as I go back, it's 2 or more. But either way, we have to see the number of providers that were identified, or a number of participants that were in each group. All right. So let's move on. Why the 97530? So this is a J8A problem. So data analysis on this identified therapeutic activities as a significant potential risk to the Medicare Trust Fund, with the total dollars at risk above the 99th percentile, and an average dollars paid per claim above the 50th percentile for all Part B of A services billed in our jurisdiction. And when I say B of A, that's outpatient services that are rendered as part of a facility. So outpatient hospital, outpatient SNF, outpatient IRF. So those still run through the Medicare Part A money, even though they're an outpatient service, and they get paid, they get billed to the Medicare Part A section of a patient's Medicare. So the November 2024 final CERT report had an overall SNF error rate of 11.6%, and the July 2025 CERT forecast report has an error rate of 12.8% and identified issues with this specific code. And those problems included no documentation was submitted in response to an ADR. Documentation does not support the continued need for skilled therapy, and progress reports were completed by the physical therapy assistant, which is a no-no. And we'll talk about that when we go into coverage criteria. Now that we've discussed what we're reviewing and why, let's move on and discuss the coverage criteria that must be met when we review these services. So the Medicare Benefit Policy Manual, which is linked here on your slide, which is 100-02, Chapter 15, Sections 220 to 230. Those outline the coverage criteria for rehabilitative therapy services, so PT/OT, SLP services. The regulations written in the outpatient therapy section form the foundation of coverage for services for other places of service as well. So what I mean by that is even if a patient goes to an inpatient rehab facility, which is an inpatient stay, you always start with the coverage criteria that's outlined in the outpatient regs because that's the basics. That's where the coverage criteria foundation is formed in those outpatient regulations. Then if there's something more specific based on that place of service, like for instance, the certification and recertification regulations for inpatient services and an IRF are different than the outpatient. So then you must follow all the outpatient regulations as well as the specific inpatient regulations for IRF regarding certification. So let's break down that basic coverage criteria. One, it needs to be a need-based service. So the patient must need the services that you can provide as a therapist on that specific day by that specific type of provider. Think about why that patient needs you, your license, your training, your skills, your expertise, your skill set to make those functional improvements or maintain where they currently are if you're on a maintenance program. Second, they need to be provided under an established plan of care. So the services must be rendered under an established plan of care. And that plan of care can only be formulated by the physician or the licensed therapist, no assistance. The patient needs to be under the care of a physician. So the patient or beneficiary is the Medicare terminology for patient, must be under the care of a physician. And the physician must certify the services. So an order is not necessary, but to prove the patient is under the care of a physician, you must obtain a certification. So with the final rule of 2025 in the Medicare Physician Fee Schedule, CMS established an exception to the plan of care signature requirements. Now, this is applicable to claims with dates of service on or after January 1st of 2025. This new exception allows a signed and dated order or referral to meet the certification requirements. As long as the order is in the patient's medical record, so you maintain it there, and you also have evidence that the plan of care was submitted to that referring provider within 30 days of that initial evaluation. So previously, the therapist would need to submit the plan of care to the provider within 30 days of the initial treatment, and the provider had to return the signed and dated copy of the plan of care. So this allows for an order or a referral to serve as the initial certification, not recertification. Now remember, the order is not required. So if you don't get one, then you still have to follow the certification rules, and you still have to get that physician to sign the certification. All right. So now that we know what we're reviewing and why, as well as the basic criteria for coverage, now let's shift into how do we support what we're providing, what we're doing for our patients? How do we support that as medically reasonable and necessary and in accordance with Medicare regulations? And that's through your documentation. On this slide are the general principles of documentation. These are the general principles no matter what type of service you are rendering. You should strive for your documentation to be like this wherever you work. So it includes things like your documentation needs to be clear and concise and complete and correct. It needs to be patient-centered, needs to be comprehensive. Remember, when you are documenting, you're not only supporting what you build, but you are also painting a picture of what you're doing for your patient. Without all the colors in the pictures, we don't have a complete painting. Whoops. All right. So let's talk about the components. So the AKA the pieces of documentation that are required, starting with evaluation and reevaluation. So the initial evaluation and plan of care is due before the first full treatment day. So that doesn't mean that the evaluation the evaluation day cannot include treatment. You surely can evaluate and treat on the same day, but that treatment plan must be put into formal writing before the next date of service. So it must be written by the therapist. It's got to contain goals, diagnoses, type, amount, frequency, duration of your therapy services. And it can only be changed or updated by the physician or therapist. Reevaluations are not routine. They are only required when there's been a significant change in functional status that warrants a reevaluation by the therapist. Next is certifications and recertifications. So the initial certification is due upon admission or as soon thereafter as is reasonable and practicable, but it must be obtained within the first 30 days. And remember, an order or referral can serve as that initial certification, but it's got to be kept on file by the therapist, and you've got to keep on file proof that you did send that to the physician. Your evaluation and certification recertifications are valid for 90 days or the time frame listed in the plan of care and certified by the physician. So if you said 4 times a week for 4 weeks, then your certification is only good for 4 weeks. Or if there's a significant change in functional status, you would need to get a recertification by your physician as well. So again, 90 days, duration of plan of care, or when necessary, reevaluation must be performed, you must get a recertification. Progress notes. Progress notes must be completed by the therapist, not by anyone other than the therapist, and they must be completed at least every 10 treatment visits or less. They cannot be performed by an assistant. The discharge summary is part of your progress note, and it must be completed upon discharge. Even if the patient leaves AMA, you should still close out that chart with a discharge summary, noting what you did know when that patient left your services. And then treatment notes. Treatment notes are required to support your daily billing. At a minimum, we need to see what was performed, who it was performed by, and the actual minutes of therapy provided. Not the time the patient arrived and discharged to the therapy center, to the therapy clinic, to the therapy room, but the time spent in each modality of service. And then finally, signatures and credentials must be contained in your documentation. So who did it and what their credentials are. So to support intensity, complexity, and skilled nature of outpatient rehabilitative therapy, your documentation must clearly demonstrate the patient's condition requires your unique expertise as a qualified therapist. So services that can only be performed or that can be performed by non-skilled personnel or caregivers are not considered skilled, even if they're performed by a therapist. So some of the key documentation requirements, medical necessity. All services must be reasonable and necessary for treating that patient's condition based on, acceptable standards of medical practice. Skilled care. So your documentation must show that the service is a level of complexity and sophistication. Again, that requires the therapist's specialized knowledge and skills. Objective and measurable. Now, if you take away anything from today's webinar, take away those two words, objective and measurable. Anytime you can document in objective and measurable terms, a length, a measurement, a percentage, a weight, it will behoove you to do that, because then we can really see from progress note to progress note the differences that your services are making. So using subjective terminology is not in your best interest. You can give us the subjective information that your patient tells you, but then follow that up with objective and measurable. For instance, the patient comes in and they say, I'm just feeling lousy today. I'm just in so much pain. Well, let's define that, Betty. Like, what is your pain level today? Your pain is an 8 out of 10. Well, then that is now objective and measurable. So her subjective information of, I just have so much pain, is now quantified by objective and measurable information. All right, plan of care. So again, you have to have a plan of care. It has to be written by your therapist or the physician, has to be certified. It must contain diagnoses, long-term goals, type, amount, frequency, and duration. And then we move into like prior level of function and current level of function. So again, your prior and current levels of function, it should be right before the illness, injury, accident that caused the patient to need your therapy services. Not what they used to do 5, 10 years ago. We need to know what's precipitated now the need for therapy services and where they were just prior to that. And then again, objective and measurable. And then finally, your daily treatment note. So each note must paint a picture of that session. Describe the specific skilled service that was provided. It's only going to behoove you to document that patient's response to that service and any modifications to the treatment plan based on the patient or based on the therapist's clinical judgment. So if you as a therapist are noting that something's not working and you need to modify the plan of care because of what you've seen in the daily service, then that should be identified. So again, it really is a good practice to not only tell us what service and how many minutes and who provided it, but if anything unusual happens for that day, the patient, has any information that they subjectively say to you, it's really just going to benefit you to make sure you capture that in your documentation as well. All right, so linking goals, interventions, and outcomes. So you need to create clear, direct relationship with your plan of care. So that helps to demonstrate your medical necessity. It needs to be patient-centered and functional so that those goals must reflect that patient's need, their functional limitations, why they need you. Think of the SMART goal framework, which is specific, measurable, achievable, relevant, and time-bound. This is really going to help ensure clarity and allow for objective tracking and progress of your patients. Medical necessities. So every intervention must be clearly tied to achieving those established functional goals. That's really going to help with your medical necessity. Regular review. So progress towards goals should be assessed regularly. And the plan of care should be modified as needed, and make sure, again, that your plan of care is only being modified by your actual therapist. All right. So let's now move in and talk about some of the documentation that would be expected for some of these specific components of our review. Documentation of therapeutic procedures. Again, therapeutic procedures, one or more areas. This is a time code, 15 minutes. And this is usually some sort of therapeutic exercises to develop strength, endurance, range of motion, and flexibility. So aerobic conditioning, your post-surgical rehabilitation, your range of motions, your stationary bike or cycling, treadmill walking, chronic pain management. So to support this code, we would need to see the functional limitations or impairments that necessitate the therapy services. This includes relevant history, medical and therapy diagnosis, and your assessment. Show us why that direct supervision is necessary. In performing therapeutic procedures, show us what specific procedures and techniques are being used, like what exercises, what task or activity you're doing, and how much time was spent on this exercise or procedure or task. As we move into the documentation of neuromuscular re-education, things we're going to look for again is diagnoses, and we need to see some sort of diagnosis that supports the need for neuromuscular therapy. What's that patient's impairments? What's the neuromuscular impairment, such as poor balance or decreased coordination or, abnormal posture? Your goals, again, should be clear and measurable goals that patient should be expected to achieve, such as improved sitting or standing or balance or enhanced motor controls. So, there are different techniques, modalities that can be used that we would look for. Proprioceptive, geez, I'm like not being able to speak today. PNF. These are just some of the exercises and tests we would look for. Balance and motor control activities. Are there balance boards used for performing these tests? Did they do the timed up and go test? Postural training, stabilization programs, even gross and fine motor control tasks. So we're going to look for your patient's progress. We're going to look for the patient, to be moving towards achieving their goals. We're going to be looking for the amount of time that was spent on the specific neuromuscular activities and any kind of skilled interventions, again, that were provided. So when we talk about documentation of therapeutic activities, specifically for the 97530. And again, this is therapeutic activities, one-to-one patient contact, use of dynamic activities to improve functional performance, each 15 minutes. More detailed guidance, can be found in our local coverage. We don't have a local coverage determination on that. Anyways, sorry. I got off track. So anyways, things that we're going to look for in documentation of therapeutic activities. Things that describe your dynamic activities, like movement patterns used to accomplish tasks. Again, I talked earlier about, the picking up a box and being able to place it on a counter and how that relates to the overall bending and squatting and lifting, and those ING activities such as carrying, lifting, handling, reaching, transferring. Those are some of the specific examples that help us to see that you're actually providing services that do fall under the therapeutic activities. So consider the intent of the task. Like for squatting, Are we using it for strengthening and build under a therapeutic exercise? Or is, are we doing it for muscle strengthening? So that's kind of how you determine if it falls under a therapeutic activity or a therapeutic exercise. All right, so the documentation of group. When reporting the group code, we need to see how many people were in the group and what therapeutic procedure was being performed by the specific beneficiary that we're looking for or looking at. So the documentation should include the goal of the group being performed, as well as the documentation needs to support that this group activity relates back to that patient-specific goal. So we need to see who was supervising the group. Remember, all the patients do not need to be doing the exact same task, but the group should be working towards the same overall group goal. So different patients may be performing different activities, but maybe they're all working on a component of something like balance. Remember, with group, you can only bill once per session, regardless of the amount of time spent. However, you should still be documenting overall minutes of service. All right, so we get a lot of issues with what's on your slide now. Documentation that must be performed by the therapist. There are some specific components of documentation that must be completed by the actual therapist or physician. So that includes the evaluation and reevaluation, the plan of care with goals, any changes to that plan of care, progress notes or progress reports. This includes your discharge summary, and that again has to be done every 10 treatment days or less. So if we find that one of these things is done by someone other than the therapist or physician, but it's rare that a physician's going to complete that, your services may not be favorable on review. Let's see. I see a question came in. Can a patient be seen by a PN, seen for PN, what's PN? By the therapist and PTA providing treatment on the patient same day. How does the MDCR payment rule? Medicare. Okay. The question, okay, progress note. Sorry. Yes, a patient can be seen by a therapist and an assistant on the same day. It just needs to be evident in your documentation that the therapist was the one that completed the progress note or progress report for that patient. But yes, they can have active treatment by an assistant on the same day that the therapist completes their progress note and notes any changes. If it's one document that prints off for you, make sure that it doesn't appear that the assistant was the one to sign the progress note. There are some electronic documentation systems, and since both people were in doing work on that same day, that the signature comes out and it appears that the assistant is signing a progress note and that they are the first one on the progress note, and then the therapist is then in essence co-signing it, which is a big no-no. So I would just double check your documentation, how it prints off for that date of service, because if you're ever under review, you need to prove that those were done by two different people, that the actual activities whatever for that day under the plan of care were provided by the assistant and that the progress note was completed by the therapist. Some EMRs create 2 claims on the same day since both documents are separate. And that is fine if your electronic medical record does 2 separate things. It can't go into the billing system as 2 separate claims on the same day because that will kick for duplicative billing. But, you know, if the EMR creates them separate, if you guys keep them separate, that is just fine. Okay, so let's move on to review findings. So we're going to round out this webinar by discussing some of the common review findings for these targeted probe and educate reviews. And I'm going to discuss them by actual denial reason code and then the issues related to them. Let's start with the first denial reason code that you may see is, and this is an outpatient, TP001. So documentation does not support the plan of care was established and signed by a qualified clinician or practitioner. Remember, only the therapist or physician can establish or change a plan of care. So make sure your plan of care is signed. Make sure your credentials are on that. Next is the TP002. So in this denial reason code, the documentation submitted did not support the approval or certification of the plan of care for therapy services. So again, no approval, no certification on file. Remember, for that first certification, if you have a physician signed order or referral, that can be used for your initial certification. And I just trying to drive that home because that was a change for 2025. Just as a reminder, but that only serves for that initial. TP004, this reason code means that the documentation submitted did not support the reason for a delayed certification. So in the benefit policy manual, 100-02, chapter 15, section 220.1.3D, there is info on delayed certification. If a certification or recertification is delayed, there are provisions in the regs that must be followed. This includes evidence the provider or supplier considers necessary to justify the delay. So upon review, if there's a delayed certification, we're going to look to see what the physician's justification was. So that physician should be sending some sort of justification statement along with the delayed certification. TP7007. So in this denial reason code, the documentation doesn't support that plan of care was certified within the duration of the prior plan of care, or within 90 days, whichever is less. So you didn't meet the time frame. So this plays into supporting the reason for the delay. It could appear as either the prior, we don't have a reason, or this one, that we don't have, the documentation in the time frame that it's supposed to be. Remember, your certifications are good for 90 days or the duration of the written plan of care, or if there is a necessary reevaluation done, then you have to have a recertification. So most likely in this case, there was a change in status that necessitated a reevaluation, and the old recertification schedule was kept, and they never got an update. TP100. In this denial reason code, the documentation submitted did not include an initial evaluation to support the therapy service bill. Remember, it's so important to remember this key component. Regardless of the dates of service we are reviewing, we always need that initial evaluation and plan of care to be submitted with it. We must know where your patient started, what the long-term goals are, what the baseline testing is. TP 300. In this denial reason code, the documentation didn't include completed progress report. Remember, the progress report must be completed by the therapist, and it needs to be done at least once every 10 treatment visits. It can be completed more often, but not less often. And it must be formulated by that therapist or the physician, never by an assistant. Progress reports that appear to be formulated by an assistant will be grounds for denial. So if your assistant is providing you a summary of the time with that patient for your progress reporting period, you should make sure you include that as a supplement to your progress report. If it looks like the entire thing was written by the assistant and only co-signed by the therapist, again, that's going to be grounds for denial. TP 301. In this denial reason code, no signature by the therapist or physician on the progress report. So this kind of goes hand in hand with the prior denial reason code as well. Remember, if we can't support the correct person completed it, it could be grounds for denial. The TP 303, not meeting the time frame of the progress report of once every 10 treatment days or within 7 calendar days from the end of the reporting period, so the end of that episode of care for that discharge summary. All right, so TP 400. This denial reason code, the documentation lacked evidence to support the ongoing skills of a qualified therapist were required to be completed, or required to complete the treatment, I'm sorry. When services begin to be repetitive or lack skill, then the licensed therapist is no longer needed to provide the service. If anyone like the caregiver can continue with the patient and it's no longer skilled and we're not trying to make any kind of functional improvements with this patient or maintain this patient's current condition in a maintenance type situation, or that patient plateaus and there's just nothing else being done to adjust that treatment and move through that plateau, then services are no longer skilled, and you may see this denial reason code. TP 501, the documentation didn't include treatment notes for the date of service, or they lacked elements of the note, like description or modality or total treatment times or signatures. So remember, we need to see those daily treatment notes to support what's on the bill. The TP 903, remember when services are furnished in whole or in part by a therapy assistant, then the appropriate modifiers for PT/OT services must be appended to the claim, and that's the CQ or CO. I have Jennifer put a link to a CMS article, which is entitled Billing Examples Using QO or CQ, CO modifiers for services billed in whole or in part by PTAs and OTAs. You're gonna wanna make sure you're following the guidelines for correctly reporting these services. If you don't know these guidelines, you really need to go out and make sure you are reviewing this if you are using PTAs or OTAs. And our last denial reason code is for documentation submitted that doesn't support the services were rendered as billed. Either we did not receive the documentation to support the bill, or it was reported using an incorrect code, or just didn't exist, but it was reported on the claim. Regardless, your documentation must match what is reported on your claim. We can't, in good faith, pay you for services that aren't supported in the documentation. So it goes back to that old mantra: if it's not documented, it's not done. And this happens to be me and my first knee replacement. All right, so let's finish out by talking briefly about connecting the review findings to overall compliance. So it's important to remember that the reason of our review of these services are based on utilization of the codes that we talked about. Those individual codes are not the full scope of compliance for review. So you've got to be compliant with all the coverage criteria to have your claim considered for coverage. So just because those CPT codes were on it doesn't mean we can't deny if we see that you're not following the overall coverage criteria. So documentation principles that we spoke about apply across all therapy services, PT, OT, and SLP. Except SLP in those cases where we talked about assistance, SLPs don't have assistance. So speech language pathologists don't have assistance. So those particular things don't apply to them. It's important to accurately code your claim. So incorrect coding could cause denial of services. So you must support every CPT code on your bill. If you work to improve your documentation and think about painting that picture of your services, it's going to strengthen your overall compliance with your Medicare billing. And then just some resources that I do encourage everyone to go out and take a look at. This is just going to take you out to that benefit policy manual. This is a good resource that's on our website about therapy assistants and what they cannot do. There's information on CMS's website and our website. This is one to our website that's going to take you to some information about the outpatient therapy services that are currently under review. And then information about those CQ and CO modifiers. We have some actual fact sheets out there. So let's recap before we look at any additional questions. We went through a lot today, and there's even more I could say about therapy services. I could talk for days on therapy services. But the purpose of today, we identified those key Medicare coverage and documentation requirements for the outpatient rehab services, and what's under review and why it's under review. And we achieved all this today by going through that coverage criteria. We talked about the documentation for outpatient therapy. We talked about those specific codes that are driving the reviews and the documentation for those as well, and common medical review findings in an effort to avoid those review findings within your own facility. So at this time, I know we have about 5 minutes left, and I am just looking through the chat to see if there were any additional questions that came in that we did not cover during the live event. And I am not seeing any. So in the interest of time, I'm going to continue on, but I'm going to check back into the chat before we close out today and see if any additional questions came in. There is additional information on the note sections regarding this in the note section of this slide, but I want to highlight the fact that if you're going to be a Medicare participating provider in 2026, you should read the annual Medicare participation announcement linked on this slide. It links you out to an article on CMS's slide. And it basically says by December 31st of 2025, so in a couple of weeks here, all physicians, practitioners, and suppliers, regardless of their Medicare participation status, you have to decide whether you're going to again participate in Medicare for 2026. If you don't need to do anything if you're already participating and you want to continue your participation, or you're not currently participating and you continue to not want to participate. But if you're not currently participating and you want to participate, then you need to follow the information in here. Or if you are participating but you want to opt out of being participating provider, then read the information here. So it's going to give you more information on how to change your Medicare participation if you so choose to do so. We value your opinion, and I want to hear from you and how we did on this event. So this survey only takes a few minutes to complete, and I would appreciate everyone taking just a few minutes and completing that for us, and that's why I'm giving you the opportunity to take it now. It's also your opportunity to tell us what additional education you would like in the future. So many of those educational events that we do are a direct result of those requests. So be sure to read the responses carefully, making sure you know how you're ranking that order on the survey as well. And you'll have a couple of options when the webinar closes. It will automatically redirect you to take the survey, and a site will pop up that looks like this, and you can go ahead and click on the link. Otherwise, Jennifer placed it in the chat as well. And before we finish, I see a question came in. Can you clarify supervision of PTA, OTA when the original evaluating therapist is on PTO and how to document? So again, follow that information on those things, but if the services are pretty much in whole or in part by that assistant for that day of service, then you're going to need to append the correct modifier to the claim and who that patient, if that assistant is working under the direction of another therapist that day, that therapist is assuming overall responsibility of that patient for that day, then, you should just note that in your documentation. But otherwise, when it comes to billing, and if it's for PTA, OTA services that are rendered in whole or in part, and the article is going to tell you, I believe it's like 80% or more, then the modifier would need to be appended to the claim. So I think that helps with that, evaluating therapist on PTO. Yeah. So they would document as they normally do. Your documentation in-house is going to support who their supervising therapist was for that day. But if the services for that day, again, are completed in whole or in part, and it meets those requirements for those CQCO for billing, then you append those, and it's a reduced amount, but it's not you, the licensed therapist, providing those services. So it's being paid now at the rate that we would pay for your assistant to provide the services under you. All right, so that takes us to the end of our webinar. If you have any questions regarding this event, you can email those questions to us. The email address is also in the notes section, and Jennifer placed it in the chat earlier today. Please don't send us any PHI or PII. Remember, we don't have access to the claims processing system. So if you need to find out about a specific claim, you're going to need to take those questions back to customer service. Again, remember to check the notes section of the slide deck for any additional information we want you to know. So on behalf of myself and Jennifer, as well as our medical review department, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.